but will not wait anymore because we are already in the discussion. So the goal of this lecture, to say, is to understand or to think always about eye diseases which could be which could manifest in other system, or the other way around, a systemic disease which can give you an ocular manifestation. For example, I remember a case of a patient. She was a female patient, about 42 or something years old. She was presented in the clinic with bilateral retinal detachment. Okay, bilateral retinal detachment. So right and left eye. Okay. Upon further examination and further questioning, and the patient was admitted, it was an exudative retinal detachment. That means that there is fluid accumulation, yeah, under the retinal layers. So after admission, we took the case for further investigation because we knew that this is something systemic that gives you the picture of bilateral retinal detachment. Bilateral retinal detachment is rare, but it can happen. It can happen. Whatever. Sometimes one eye get a retinal detachment because of a hole in the retina, and then after 1 week or so, the other eye get another retinal detachment. The patient is ignorant or he didn't notice the first eye, and then he came after the second eye. Then you would discover it, and maybe the pathophysiology here is straightforward. But when you have exudative retinal detachment, so you have to think about something going on systemically. So upon further investigation and examination, we found that she have VKH. Anyone knows what's VKH syndrome? Did you take dermatology yet? Derma? Not yet. Okay, good. It's Vogt Koyanagi Harada. Yes, yeah, Reem. Mumtaz, Reem. Yes. And what are the manifestations, Reem? If you know it, then you know the manifestations? Other than retinal detachment?
Sometimes headache.
Okay. What else? Hotone. Yes, good. Hotone. What else?
And sometimes it's affect ears, I think.
Yes.
Give sometimes meningitis when it's
yeah. خلينا في ears. ها. What happens في ear? Ptotic tinnitus. Yeah. The patient will describe it as he is hearing some annoying sound in his or her ears, yeah, and vitiligo. You will see the whitening of the eyebrows and lashes. This is correct, yeah. So if you further examine the patient, you will, I mean, in that patient, when we further examined him, we found all of this picture. So it was the first diagnosis by us in ophthalmology that the patient have VKH. Okay, good. So that was just about the idea of this lecture. And here we go. So as we said, good. The objective, I told you about it already. There are some things here in the lecture that you already talked it with other colleagues. retina خدتوها صح؟ ايش اللي باقي؟ طيب بس I want to look at this here. Okay, just ocular tumors وبعدين injuries. Okay. There are so things about hypertensive retinopathy and diabetic retinopathy. These things, I assume that you already took it with other people. So they always say that the eyes are the window to the soul, so you can see so many things just from looking at the eyes. Whenever you have any disease, you always go through your differential, yeah. So the differential diagnosis, you know it already from your basic pathology: congenital, vascular, traumatic, neoplastic, autoimmune, idiopathic, infectious, whatsoever, yeah. And then any patient presented to you in your clinic, you will after taking a detailed history and targeted history. By the way, I know that most of you didn't, or you just went one time to our clinic. But you have to know that after graduation, after you are facing the real world, and you are, for example, you are a resident in ophthalmology, for sure you will not go through everything in history like internal medicine, but you will follow the structure, the main structure, and then your history should be targeted to the things related to to the condition of the patient. Because otherwise you will be just a resident who waste a lot of time talking to the patient before even examining the patient. Okay. So this is just something to put in your mind. Examination, you start the normal ophthalmological examination, and I assume that, or I think that all of you know it by now. By the way, just before we go further, for that patient with the fake AH, what you will do as an investigation? Ocular investigation. You did the examination, you are seeing that she's having a bilateral retinal detachment. And you are not sure about this detachment. This scan is okay. This scan is correct, but another investigation, because as we have said, we are thinking about something going on under the layers of the retina as a result of accumulation of fluid. Yes, OCT, ممتاز. OCT, yes, OCT. If you do OCT for a patient with VKH, you will see it's like a dome shape, but it's wavy. It's like the waves of the sea. Yeah. So hypertensive retinopathy, I think you already took it with my colleague. You have to think about things which can be manifested as a result of a hypertensive crisis. Yeah. Okay. So what are the things which can complicate hypertension, or which can result in ocular disease caused by hypertension, away from hypertensive retinopathy? Not hypertensive retinopathy, other things. DM. Okay, but bleeding is always right. What else? Okay. Okay. Hypertension is a vascular disease. Yes. So you will think about anything going on with the vessels. Yeah. Like what? Occlusion. Hmm? Yes. Yes. Most of the times it's artery. Most of the time it's artery. Yeah. Good. So, can anyone describe the picture here?
دكتور
لحظة بس قبل إبراهيم. Anyone who want to describe, please raise your hand. بس 1 2 3 4 5 بس يلا, I want to see all of you and then I will choose one. See, I told you before that you have to be confident enough about yourself. If a picture is shown to you, yeah, showing the fundus, you start systemic, yeah, you start your description, you go step by step, you describe what you see, even if you don't know the diagnosis, you just describe, and by the time you are describing it, you will come to a diagnosis or a differential diagnosis. But don't panic. Don't panic. ها؟ يلا علي. علي منيح.
I can see a colored fundus view of the right and left eye. The right eye showing disc swelling in comparison to the left eye disc. I can see scattered white. I think in comparison to the left one, it's swell or cupping more than swelling.
What's cupping?
Cupping is the enlargement of the cup itself. The whole disc will swell.
Do you mean that here is the papilledema?
I can say papilledema without further investigations.
Okay, carry on.
And I can see scattered whitish pigmentations appear to be cut and wall spots. It's probably due to ischemic injury to the retinal nerves. In the right eye, the vasculature is less prominent than the left eye, maybe due to proliferative change in the left eye or decreased vascularization in the right eye. Yes.
What else?
هذا اللي لاحظته.
Oh, good. ممتاز علي. Just my comments are, first of all, for example, here you cannot really comment on the disc, on the cupping or the disc, because you are not seeing it clearly with the reflection of the picture itself. So you will start describing the things which you are seeing. Yeah, you said about the cotton wool spots. Yeah, it's better to name it like lesions. Yeah, other than pigmentation, you can say scattered whitish lesions. Yeah, and here, what's this? Here.
Leakage.
And here. What is it? Other than علي. شكرا لك يا علي. ولا مين هذا؟ سحباني ولا مين؟ أنا قاعد أشوف.
سحباني أنا اللي.
يلا روح سحباني. What you are seeing?
Leakage from the blood vessels.
طب leakage from blood vessels, what we name it? hemorrhage. أيمن hemorrhage.
يسميه هيموريج، يعني أصلا يسميه هيموريج.
إيه ليش لا؟ strict hemorrhage. أو pinpoint hemorrhage إذا كان هنا نقط بس. أحيانا في الأيرلي diabetic retinopathy non-proliferative you will see just a scattered pinpoint like hemorrhages. Yeah, just small, very small hemorrhages and microaneurysm.
تمام دكتور.
Okay. Can anyone tell me what's the difference between hard exudate and cotton wool spots? راحة. Go راحة يلا. ما نسمعك يا راحة. وطبعا
طيب الاسم القديم للكوتن وول سبوتس كان السوفت اكسوديت. الفرق بيننا اتوقع على حسب الشكل يعني انه الهارد اكسوديت more yellowish and more brighter than the cotton wool spots. برضو الكوتن وول سبوت ممكن يكون اكبر بالسايز.
طيب any other idea؟ علي يلا، ولا لحظة علي كم، يلا روح علي بعدين نشوف سارة المرة الجاية. يلا علي قول.
In addition to the morphological differences that said by Watwan, the pathogenesis is different. In the hard exudate, the exudate is it's explained by its name, it's exudate from the vessels, while the cotton wool spots is the nerves injury due to infarcts, showing an exoplasmic swelling as a reaction to the ischemia.
Perfect. Very good and scientific explanation. Okay, Sarah, when Sarah? How to differentiate clinically? Yes.
It will be if cotton wool spot will be superior to the vessels, but if hard exudate, it will be around the vessels. And as Ali said, it will be if hard exudate, it will be from pre-capillary arterioles, but in the cotton wool, maybe from retinal fiber microinfraction.
Correct. Yeah. And like Watwan said, Watwan, he just described how it appears, yeah? And they said that the hard exudate is most of the time it's well-defined, well-demarcated, and it's as Sarah said, deep to the vessels. Cotton wool spots are superior to the vessel, ill-defined, and it's bigger, yeah? The pathophysiology or pathogenesis, I mean, as your friend Ali said. Okay. Okay, you got it? Good. You have to describe, yeah? So the most likely diagnosis is? Diabetic retinopathy. ولا hypertension. هنا hypertension. ليش؟ Because of this. Cotton wool spots, retinal hemorrhages, narrowing of the vessels, yeah? The retinal ischemia and neovascularization can happen. It might be associated with any vascular disease, as we said before. Sometimes there will be, you will see a patient presented to you with central retinal artery occlusion, for example, And the only thing in the history, or the only risk factor that he have, is hypertension. And maybe he don't know about hypertension, because most of these people are young, young male or young female, in the beginning of their 40, so they rarely check their blood pressure. But it could be that they have hypertension, for example, for 5 years or more, and then they develop this. Yeah. I remember a case of a patient. She was a young lady. She was also in her 40s. She was presented with central retinal artery occlusion. And sadly, she was presented late. And she lost her vision in that eye. There's nothing to do about it. This is how serious is it, yeah? Especially with artery occlusion, and especially with central retinal artery occlusion. What's the window time? Do you know that? What's the window time during which you can try to save the eye, or to save the vision of the eye, because the eye will be always there. Okay. What else? It's up to Nora. It's up to 4 hours. Less than 4 hours. Less than 4 hours is you still can do something. Yeah. What are the things which could be done? Central retinal artery occlusion. What you can do as an emergency management. Okay. Yes. All of it is written in books, and it's right, but reality and the new modality, if you are in a good hospital, you will just call your radiologist, interventional radiologist. And if you have a good interventional radiologist who is willing to help the patients and to save organs, or to save function of organ, he will discuss with you. He will discuss the case with you. And if the patient fit, he will come from his home and do it. Because most of the radiologists, they are doing teleradiology. They will stay at home, and you are the resident having doing your on call, and you get a patient with central retinal artery occlusion. Yeah. During my time, I think I called once, and the other patients were already didn't fit the criteria. I called once, but the patient was having other problems. That's why the interventional radiologist didn't want to go and to come and to do it. But there are other patients with other colleagues from me. The interventional radiologist came, and he did it. So radiology is good. Yeah, some people will say that the radiologist will just comment on pictures and that's it. No, if you are an interventional radiologist, you can do it. Interventional. What he will do? He will go and try to dislodge the emboli. What's the occlusion? The occlusion is an embolus. Interventional radiologist will just dislodge the emboli. And okay, And what's this here? Can anyone describe? Describe. Ayman.
Fundoscopy, which shows the optic disc, which appear to be swelled a little bit due to papilledema, maybe.
What else?
What else?
Yeah.
New vascularization.
No.
A hemorrhage.
We said this before. Yes. Yeah.
Yeah.
Hemorrhage. Yeah.
Yes.
Hemorrhage. So you'll say a picture showing a colored picture of the fundus showing the optic nerve with irregular boundaries or ill-defined boundaries with hemorrhagic streaks around and most likely هنا بعد إيش فيه? You can see here. What's this? I don't know if it's clear for you. You see this? Yeah. What does it mean, Dalal?
There's elevation that causes curvation of the lens.
Yeah. 3D. Think about it like 3D. Yeah. Very correct. Correct. Nice. Okay, then diabetes. You know this that the pathological changes are the microvascular damage leading to hypoxia and then vascular leakage, edema, ischemia, and then new vascularization. عبد العزيز تفضل.
زاد فضلك دكتور. نقدر نقول يا دكتور الصورة اللي راحت فيه انجورجمنت في الفين.
Yes.
الريتنا.
Yes. Yeah. Very correct. Here, you can see.
جميل.
And I was waiting for somebody to say it. Okay, good. Pathological changes. Do you know what does this mean? Microvascular damage. What's the first thing to happen in diabetes? In diabetic retinopathy? Correct, but I mean, okay. And leakage, occlusion, yes. Leakage from, why it's happening, leakage? Ayman, yes, Ayman, you were with me. يلا توك يا أيمن. افتح المايك. أنت عرفتها بعد الكلينيك. إيش يصير؟
راح يكون في increased permeability in the capillaries.
Why?
blood capillaries.
Why?
لا إيش كانت؟ ما أتذكر ليش السبب والله. لكن مو هو دائما.
This is correct. This is correct. It's yeah. This is correct. It's just for you to know. Sometimes, if you know the pathogenesis, yeah, due to Abdul Majid, how?
Maybe by the thickening of the wall.
Yeah. شوف هذه معلومة بس لكم طيب just for you. يا عبد الله.
الدكتور عندي الميكانيزم اللي حقت الادفانس جلايكيشن اند برودكت اللي هو لما يكون البلود شوجر زايد بالدم راح يسوي لي فورميشن اوف ادفانس جلايكيشن اند برودكت. هذا الادفانس جلايكيشن اند برودكت بيرتبط بالريسبتور اللي هو موجود بالليمتري سيلز والسموث ماسل بالبلد فاسلز. لما يرتبط راح يسبب لي release of cytokines and growth factors and others which cause leakage or which cause permeability of the blood vessels.
Good. Good. Thank you يا عبد الله. وفي حاجة ثانية بعد بكم تقرونها سواء الآن أو بعد الكورس، أنتم حرين في شيء اسمه tight junctions. الدايابيتس very very important. حتى لو أنت بتصير surgeon لازم you have to know it. Once you know it, well, for one time you know it as a sequence of event, then you will always remember it. Yeah, and then you can think about your intervention, when to intervene and what to do. Okay, so good. طبعا لما يكون عندنا macular ischemia، لما يكون في ischemia حيكون في ايش؟ new vascularization. يلا someone describe. رهف يلا رهف.
This is fundus of the left eye. There will be dot blood hemorrhage, and there is area of hard oxidate and new vascularization, and the blood vessels are swollen, so it's most probably is proliferative.
Okay. Okay. Good. Thank you, Raha. So always start from here. Yeah. Try. The answer is correct, but I mean, if you want to describe the picture like this, so start from here. Yeah. Start from optic nerve. Yeah. Say there's the optic nerve. I cannot comment, or you can write that there is a reflection of light in the optic nerve, no details. Vessels are engorged. There are dot blood hemorrhages and also pinpoint hemorrhages, and there are hard exudates, and there are what else here? New vascularization. Yes. Yeah. Yeah. If you are looking carefully, you will see the new vascularization. Here it's more prominent. You can see it here very clearly. So this is new vascularization on the disc and here elsewhere. And how to manage? Management. Good. والله الريم you are ophthalmologist already, huh? Anti-VEGF 3 times. Okay. Vitrectomy. Number 1 treatment. Sadine laser. Okay. Yes, يا أيمن. يا سلام. Yes, أيمن. Good. Always. Huh? So if أيمن كان معانا في الكلينيك, always عندك diabetic retinopathy, first thing to do, you control the diabetes. Because whatever you are doing with the eye, if you are not controlling the cause, the patient will come to you after 1 month with other complications. So it's of no use. And by the way, they are very, very difficult patients. The patient who reached diabetic retinopathy is I can say it, is an ignorant patient. If he knows that he is having diabetes. Because most of them, they know that they have diabetes, but they don't want to control it. Or they are reluctant to stick with their treatment plan. They are not doing investigation. If you ask about the investigation, they will say that they didn't do it for can be seen. Yes. Yes, يا أنس في. You can see it, Anas, but let me finish. But this is the first thing to do. Yeah. I have seen patients with amputated limbs waiting for their dialysis. In the same day, they are coming to the ophthalmology clinic because they have diabetic retinopathy. And here, your management will not be directed only toward the retinal findings and the retinal disease, which is caused by a systemic disease, but rather you have to control your systemic disease in order to be able to control the retinal disease. And some patients, I remember a patient, she was operated. She got everything that you think about, anti-VEGF, laser, vitrectomy, 4 times. After the 4th time, the senior consultant there, he just dropped the pen and he said, I can't do it anymore. Because he's saying that this is of no benefit. Yeah. Because every time it's coming with the same complications. She's totally messed. Yeah. So sometimes, or the best thing to do with the patient with diabetic retinopathy to control their diabetes through their internal medicine physician, and then you manage according to the finding. Yeah. For Reem and other colleagues who are saying about anti-VEGF, laser, Sadine, and yeah, it's correct. But there is a management plan. It depends on the macula. Is there a maculopathy or not? Yeah. And then according to that, you will decide. You will give anti-VEGF or you will start with the laser first. And there are protocols, but it's not required from you at this level. There are protocols to follow, to do what to do and what is the interval between the injections. Yeah, Reem, you give 3, but you have to follow your protocol. If you are following one protocol, it will say in 6 weeks interval. Another protocol will say that you inject and see the result, and so on. Yeah, but it's something not for you. For Rugeva, yes, you can see it. If you say it here, then you are correct. Yeah, but most of the times, if you want here, for example, if you describe this, it will be correct, but it's not. It's not very clear in this picture. Okay, the management, anti-VEGF, laser, and surgery, as we said before. What are these? Hard exudate. What do you call it? It's like this. Yeah, it's scar. It's scar, yeah. You are destroying, actually. You are destroying the cells. But it is pan retinal. Why it's done? Why we do the laser? Mumtaz. Yes. Yes. to try to decrease the the release of VGF. Okay. طيب, screening لdiabetic retinopathy at the time of diagnosis for type 2 and within 5 years for type 1. Why at the time of diagnosis for type 2? يلا رها.
Because sometimes type 2 is late at diagnosis.
Yeah, because we don't know for how long. Sadine, I mean, had a complication. طيب. Because we don't know for how long it was there. Yeah. For example, you are doing screening في نخيل مول, and you find a patient with increased blood glucose level, and you ask him to go, and he is found to have diabetes. Then you don't know for how long it is. Yeah, if you are the first patient to diagnose and to label the patient with diabetes type 2, you have to send the patient to an ophthalmologist. And you can write in your consultation, rule out diabetic retinopathy. Okay. Okay. I think you know this already. Carotid stenosis will give you what? What's amaurosis fugax? Anyone?
Transient loss of the blood of vision.
Correct. ممتاز. Good. Okay, there is something called ocular ischemic syndrome. Yeah, it's rare, but you can see it. I remember, I think 2 cases I have seen. Yeah, maybe 2. Patient will present it to you with pain, red eye, loss of vision, and elevated intraocular pressure. Most of the times, the patient is not responding well to the anti-glaucoma medications, and he or she is not fit for surgery, so he will end up with ocular ischemic syndrome. Yeah, so the picture could be like this. What is this? Can anyone describe these 2 pictures? يلا يا سدين. ويدي.
We can see new vascularization in the iris.
And we
in the
call
other
it
picture there is angle new vascularization.
ممتاز.
Rubeus iridis.
وهذه هنقولها new vascularization in the angle. طيب. And what are the things which can further complicate the thing, the increased intraocular pressure, is this new vascularization. Because this one is a real challenge, because if you want to do laser, it will be difficult because bleeding will happen here. Yeah. But rather you can do something like a cryo from outside. You took it? Anyway, there is a way to okay. What's cryo is with a probe. It's a probe with -50, -60 degrees, and you fix it at a special location to try to destroy the cells which produce the aqueous humor. So in order to decrease the ocular tension. The most important thing here to know is the complication of ocular ischemic, or if you have a patient with ocular ischemic syndrome. Yeah, I remember a patient. She was presented with such a picture. She was brought to me late in the night. She was in a geriatric hospital, and she was presented to me because she's having pain. Upon examination, I think the pressure was about 55 or something, both eyes. And she is a well-known patient with carotid stenosis, up to 80%. And the problem is that she's not fit for anesthesia, for general anesthesia. So that's why she was not operated by the vascular surgeon for the carotid stenosis. And she's presented to you with ocular ischemic syndrome. And she can die at any minute. Why? Because of that, yeah? Because of the carotid stenosis. So you have to be very careful with such a patient. And for her, we just booked her for an early morning crew, and then we just try to reduce the pain what she's having under local anesthesia, and that's it. And we send her back. Sometimes you are stuck. You cannot do the things which should be done because of the general condition of the patient. Sickle cell disease. Nowadays, it's not that common. If you are working in Sharqiya and Dammam, Khubar, Yatif, maybe you will see it. It's more or less is the same mechanism: ischemia, neovascularization, and then hemorrhage and tractional retinal detachment. This is a neovascularization. Okay. I think this one you know it already, the giant cell arthritis. You took internal medicine or not? But this is not also not only, yeah, but this is also from your basic. Basic, you took it, I'm sure. We take it, yeah, in basic. Okay. Very important to diagnose, yeah. What you see here is a prominent. You can palpate these vessels. Treatment is high dose systemic steroid, but you have to do biopsy before. And this is a treatable blinding disease. I can say about it, because the patient can end up blind. But if he receives a high dose steroid at the right time, then the inflammation will subside, and he will, yeah. You don't do, yeah. Don't deliver or don't give. Okay, thyroid eye disease. We took it in the other lecture, orbit. Proptosis, lid retraction, corneal exposure, and then dry eye, corneal ulcer, diplopia, and optic nerve compression. And here, always the first thing to do is to control thyroid hormone, either the endogenous or exogenous. Can anyone describe? بس عبد العزيز. من اللي ما تكلم معانا؟ البريدي، يلا.
بالصورة اليسار نشوف بالعينين فيه بروتروجن oxophthalmos.
English يا عبد العزيز.
The both eyes in the left pictures is oxophthalmos, protrusion of eyeball with the lid retraction. Also we can see the redness and edema, where in the right picture.
What do you call redness and edema, العزيز؟
redness and edema.
في الآي.
ما أدري والله، ما أحضر.
طيب ماشي، تفضل.
طيب. Where in the right picture we can see the enlargement of extraocular muscles.
Okay. What is this picture?
شلون يعني؟ ما فهمت دكتور السؤال.
يعني وش البيكتشر هذه؟ هل هي صورة شخص ولا صورة من ايش؟ من وين اخذينها؟ From where؟
اكس راي ولا ايش يعني؟
ايوه.
اعتقد انها اكس راي يعني.
هو it's okay I accept it لانكم انتم ما اخذتوا فيزيولوجي. it's MRI. طيب الجيز اللي هنا شو تسمى؟ دلال؟ ولا من قبل واحد؟
برايمري.
هي برايمري بس ايش اسمها؟ كوشر، او ممكن يسمونها بعد حاجة ثانية. ستير جيز. طيب الريدنس تسمى انجكشن. والإديمة conjunctival injection. والإديمة نورة كيموزس. يس ممتاز. So the management here for thyroid disease, thyroid eye disease, I mean, is to control the thyroid hormone. If it's controlled, and then you have to follow your protocol and to see the patient fits which criteria, and according to that, you will treat. The treatment will include systemic steroids, and if it's needed, then you can do orbital decompression, eye muscle surgery, eyelid surgery at the end, and you always encourage the patient to stop smoking. They are all smokers. I don't know why, but all of them with these complications, all of them, they are heavy smokers. So HIV. All could be in all, even euthyroid. But it's most of the time, it's mostly with Graves. But it can happen with all, even with euthyroid, because sometimes the patient was having increased thyrotoxicosis, and after that he is controlled, but there is some process still going on as an autoimmune, which can cause the thyroid eye disease. So even if the patient is euthyroid, but having a history of thyroid disease, then you have to think about thyroid eye disease also. HIV. If you get the chance to see an HIV patient presented to you in your ophthalmology clinic, you will never forget it. Because if he is that late till he got the eye complication, that means that he's having AIDS for a long time. And you know the difference between AIDS and HIV. HIV is just an infection, yeah? It could be an infection without a manifested disease. But AIDS is when the disease itself is manifested, yeah? It's acquired immune deficiency syndrome. Yeah? AIDS complication. ايش قصدك يا أنس؟ I mean, the difference, sometimes you have patient with HIV positive. Let me tell you a story which will be more clear for you. I have had two patients. One patient, he was not that way, Abdussalam. It's correct, but okay. Let me tell you the story. One patient, he was about 38, 39 years old, and he was a quiet patient, strange, very quiet to say, very respectful. And he came with something I can't remember right now, but it was not that bad. I think elevated eye pressure. Yeah, elevated eye pressure, intraocular pressure, I mean. So, as a protocol, we admit patients, and then we control their and we measure their intraocular pressure over the night, and sometimes over 2 nights. I mean 2 days. And that patient. The problem is that you are measuring the pressure. Every time you come in close contact with the patient. And at that time, we had a disposable tip for the gold matonometer. You saw it before, the gold matonometer, yeah? There is a disposable tips which can be used only once. At that time, because of the infection control, the department decided, the hospital, I mean the eye hospital decided to use a disposable tips, yeah, because every time we disinfect the tip, it was not that safe to be used for another patient. Okay, anyway, it was a disposable tip, so, but still you come in close contact with the patient at every time. During the night, I was on call at that night. During the night, a nurse came. He was a male nurse, but he was very smart, and he wanted to dig in everything about patients. And they have time to search about the patient. So he came to me and he said, "Doctor, I was checking the archive file of this patient, and I have found that he is HIV positive." I said, "What?" Yes, he was HIV positive. Yeah, but there was nothing wrong to see with the patient. Yeah, he's just carrying the infection. So I faced the patient. I called him and I asked him, and he said very simply, with a smiley face, "Yes, I have it." Okay, that was the end of the story because I was having other things to do. So I just left the patient. And the second day, we discussed with him, with the other consultants, the importance of telling the treating physician about your general condition. If you have HIV positive, it's the right of the doctor also to know, because he can come in close contact with you. The other way around, yeah. a patient came to us with a retinal with blurred vision, yeah, decreased visual acuity, and after examination of the fundus, we have found that he is having a picture mixed of everything you can think about, yeah, viral, fungal, whatever, yeah. It was a mess picture of everything. So we asked for investigation blood samples and everything, as a protocol there, we included always HIV, and it came to be positive. And it was the first presentation to us in the ophthalmology clinic. The patient was having a female companion, so you have to call the female companion also, because you have the right to know about this. And we sent the patient first to a special hospital dealing with AIDS patients, and then we followed the patient for the things which we can do about it. But he was in a need of taking control of the whole thing. Yeah. So this is the difference, because sometimes even if you are working in internal medicine, working ENT, working wheresoever, radiology, whatsoever, you can come across patient with HIV positive, but not AIDS, because AIDS, you will see the patient, you will see the picture of the patient will be ill, yeah. Shouldn't that the patient is HIV come up, taking part of examination? No. Real life, yeah, Abdul Salam, real life, you will ask every patient coming to you about HIV. You ask the patient about other diseases. You ask the patient, do you have any other medical condition? يعني بالعربي أنت بتسأل المريض هل عندك أي أمراض؟ عندك شيء؟ بيقول لك لا. طيب بتقول له طيب عندك HIV؟ عندك AIDS؟ أنت يعني تفكر فيها. بالواقع ما تقدر تسأل كل مريض بالسؤال هذا المباشر، وين ما كنت في العالم، مو بس في السعودية. You cannot say it, but if you have something, a hint about it, and you can ask. Huh? AIDS is an end stage of, you cannot say a complication. AIDS له definition. There is a definition for AIDS. Yeah, when to label patient with AIDS. Yeah. Kaposi sarcoma, yeah, it can come as a complication of AIDS, yeah. Retinitis, what's CMV? Cytomegalovirus. Treatment, ganciclovir. Sarcoidosis. It's non-caseating granuloma. I think you know it already from pathology. I mean the definition of sarcoidosis and how it appears. It can cause anterior uveitis. Yeah, this is the most commonly seen eye complication of sarcoidosis. But retinal inflammation and glaucoma and cataract can happen. This is the molten fat keratic precipitates, which can complicate sarcoidosis and perivascular inflammation, as you can see here. Rheumatoid arthritis can appear like episcleritis, scleritis, corneal ulcer, and uveitis. What's the difference between episcleritis and scleritis? Which one is painful?
Scleritis.
Correct. من هادريم ولا مين؟ Okay.
Yes, doctor.
Okay, multiple sclerosis. It's common. I won't say, I will not say very common, but it's common. You will see it. If you are going to be an ophthalmologist, you will see it as a first presentation of multiple sclerosis that you have a patient with what? Optic neuritis. Most of them are young females, female in their 40s or something, 50s. What you will do? You are suspecting a multiple sclerosis. What you will do? Yes. What you will see in MRI? All of it is correct. You will call the neurologist. Neurologist will ask you for an MRI, and then you will find the findings in it. I think I took it away from the lecture because there were students saying that you didn't took radiology, so you will see it in details in radiology and also in the internal medicine neuro. Metastatic disease, it can give you a manifestation like this picture. I have seen a lung breast cancer. It was a female. She was a female with breast cancer. First presentation to ophthalmology. She was presented with decreased vision. Yes, it's like this. Yeah, you will say, huh? What's this? No, she is well-educated young female, but the only thing which was annoying her is that she is having a feeling that her vision decreased in one eye. And sadly, it was when we do the clinical examination and we ask for angiography, and we were seeing a picture of question tumor, metastatic tumor. So what's the most common tumor in female? Would be the breast. Yeah. So we consulted other colleagues, surgery department, and the end result of this was breast cancer. Okay, so sometimes, yes, you can be the first doctor who will face such a case. Myasthenia gravis. I think you know this from pharmacology. So the things which can happen, yeah, it's all related to the muscles. So ptosis, double vision, problem in chewing because the muscles are weak, and in talking, there's something here missing, but and in swallowing also. What's the test to do here?
Eyes back test.
And what you will see? Yeah, don't. Well, what will happen? It will improve, huh? It will improve. Ptosis will improve. Neurofibromatosis. It's a rare disease. Yeah. I have seen only one case. Only one case. Marfan syndrome. major eye complication of Marfan syndrome is ectopial lentis or lens subluxation. It's common, yeah. Sometimes it comes with bilateral. I have seen a patient with bilateral lens subluxation, Marfan. But other things can also come, not only the ectopial lentis. Could be flattened cornea, causing astigmatism, keratoconus, increased globe length, causing myopia, iris coloboma, cataract, glaucoma, strabismus, amblyopia, and also vascular malformation. You can see it here. This location is upward. من اللي كان جاوب قبل ريم ولا ريم اللي قالت عن homocystinuria downward والمرفان upward. But there are other things which can be also with homocystinuria, not only the lens subluxation, but with secondary glaucoma, optic atrophy, and retinal detachment. Before we come to that, see, there are so many systemic diseases which can manifest in the eye, yeah. But the time of the lecture, and for you as undergraduate, this is enough, yeah. These are the most common, and these are the things that we can give it now. But if you are going to be an ophthalmologist, then you will study a complete chapter only about systemic disease. Well, not only chapter, but books about it. And there are so many things that you cannot imagine about systemic disease which can manifest in the eye. Yeah. Now, systemic medications. Amiodarone, which can cause keratopathy, and toxic retinopathy with chloroquine, hydroxychloroquine, tamoxifen, and also ethambutol isoniazide. What's ethambutol isoniazide is used for? Correct. Most of the times, most of the times the treating physician will send the patient to you before he initiates the medications. Why? Because he wants to be sure about the status of the retina, of the optic nerve, and the macula as a baseline, and then you can follow the patient before he starts. But whatever you write, he will give the patient the medication anyway. But he just wants that information from you: is there or not? Is there anything wrong with the retina or not before he gives the medications? Any questions? وين الليدر اليوم؟ وريني وينه اليوم؟ غايب، ما سمعت اليوم. ما حضر. من اللي حضركم وجه؟
أنا حضرت.
أنت مين؟
أنا ريم.
أنت ريم؟
ريم.
أوكي. مرة أوكي. ما شاء الله عليك والله، ضبطين وضعك. طيب يعطيكم العافية. Any question؟ بالتوفيق إن شاء الله، بالتوفيق بالامتحان إن شاء الله. نشوفكم يوم الخميس. anyway إذا كان في أي أحد عنده questions سواء الآن أو حتى بعد الكورس related to ophthalmology فحياكم الله في القسم أو في الكلينيك. لو كان أي أحد عنده interest إنه يعمل fundus examination نفس الجروب اللي كانوا معي آخر مرة، كان واحد بس motivated إنه قال تبرع إنه نعمل له dilation، بس ما كان في أحد ثاني يتبرع إنه يعمل dilation للother eye عشان تستفيدون. By the way at one يعني في وقت ما during your medical life بتحتاج إنك تسوي fundus يعني حتى لو أنت neurosurgeon، يعني على الأقل if you can see the optic nerve if you can see optic nerve and you can comment about it, is it having papilledema or not, these things